Hello and thank you for joining in on today's training. Heart & Solutions is a proud provider of CE-eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below to find and take your quiz.
Welcome everybody to another episode of You Need a Training. I am Natalie Queen. I am a therapist here at Heart & Solutions, and I'm super excited to be hosting this training with You Need a Training today. Today we have Katie Brammer with us. She has PhD, she's an LPC and RPT. She will be doing a training on suicide in the Playroom, assessment, referral, treatment, and management of at-risk behaviors. This training is going to focus on developing therapists' awareness, knowledge, and skills related to assessing, treating, and managing suicidality among youth. Before we begin this morning, I'd like to take a minute to review just a few housekeeping items. This is an APT play therapy approved training. The training today is scheduled for 2 hours, so we won't have a scheduled break, but we're all humans. Please make sure that you take breaks as needed, and take care of yourself. Once again, we have Katie Brammer here. She is a counselor educator, licensed professional counselor in Missouri, and a registered play therapist. Katie has experience as a school counselor and is currently the president of the Missouri Association for Play Therapy branch. She tailors transformational approaches into her work with the anticipation that the needs of each student and client are met, and is also proud to be a full-time faculty member at Lehman, did I pronounce that correctly? All right, college, working as a doctoral substitute lecturer. Katie is intentional about advocating for systemic change and providing trauma-informed and affirming spaces focused on cultural humility, valuing and affirming those who have been historically marginalized, traumatized, and impacted by the ecological systems and cultural hegemony. I don't know if I pronounced that one right either. Katie aims to facilitate culturally responsive learning spaces that create future counselors who are the change agents able to effectively advocate for clients and support making improvements to the counseling field on local, national, and global levels. Katie supports and facilitates dialogue about child suicide, and as a white cisgender woman, Katie continues to critically evaluate her privilege and unlearn her own socialized biases, areas of weakness, and stereotypical beliefs. She is a lifelong learner aiming to improve herself personally and professionally as an anti-racist, culturally responsive counselor educator, scholar, counselor, play therapist, and supervisor. With all that being said, I don't want to take up any more of this valuable time, so I'm going to hand it over to you, Katie, and get us started.
Thanks, Natalie. I didn't know you were going to read all of it. I would have really shortened it up for you. Thank you so much for the beautiful introduction. I'm Katie Brammer, and I am really passionate about talking about and educating on suicide amongst youth because it is happening. It is a real thing, and we need to recognize it, especially if we're working with youth. Because I still go into some trainings and people are like, how does this is not happening. What are you talking about? And it is happening. We know kids are dying by suicide. And the rates are rising. So thank you so much for being here, for being interested in learning more about it. And we'll just go ahead and jump in. There's a lot of material to cover today. Um, this particular training isn't like my other play therapy trainings where we do a lot of playful things. And I've tried to incorporate playful things into it, but that has been hard to do with like covering all the materials in 2 hours and integrating some fun experientials. So just know, this is very informational. And like Natalie said, please feel free to use the chat. I will try to kind of go back and forth. Like looking and seeing if you're asking questions or making comments. I encourage you to make comments in the chat because I'm one person. I can only offer the information that I have, but if you have other information that you think would be valuable about something I'm talking about, please share it in the chat because your colleagues could benefit from it too. And so want to also one more comment before we jump in. This particular presentation that I'm presenting on today has been adapted from a presentation that I did with my friend and colleague, Dr. Emily Brown, who is at UMSL, the University of Missouri, St. Louis. We did a training very similar to this at the APT International Conference in 2022. So I've updated it. I've added some different information, some new information to support this particular training, but it was adapted from that. So I always want to give credit to Dr. Brown when I can. As for, this me being the president of MAPT, there are no potential conflicts with this is not being presented by MAPT. This is a presentation that I'm presenting on. However, I am associated with them. So one of the things I like to start with is this therapeutic powers of play. This is very foundational in the work that we're doing because these are the powers of doing the work that we're doing. Theory gives us that framework for understanding the origin and the treatment of these concerns that are coming to us. This is kind of that philosophical perspective, and there's lots of theories that we work from: person-centered, CBT, TFCBT, Adlerian, Gestalt, attachment-based, and we do, we should be relying on these theories for treatment planning. I will talk a little bit more about why, like the specifics of theory and the importance of recognizing maybe when to be more direct and when to be non-direct during the training. So that's why I'm starting with this. And, these therapeutic powers of play are those mediators for change. So we will integrate, right? Like this is a big part of the work that we're doing is supporting youth with changing thoughts, feelings, behaviors, and in integrating these therapeutic factors with the techniques and the theory helps us to really produce this positive change amongst the youth. All right. Now, the benefits of play therapy. We understand that play is a child's language. Toys are their words. It's a really beautiful practice. And there are benefits of using play therapy with youth who are suicidal. So here are some. It offers a cultural opportunity within the therapeutic relationship and the play therapy space. It provides an opportunity to explore family relationships, structure, and dynamics. And when we're working with youth who are suicidal, we have to be working with our trusted adults. It's not an option. We can't just do this in a silo with just the youth. We have to be working with the families and the caregivers of the youth. And then, the benefit of having a play therapist who provides a safe, brave space to respond to and provide psychoeducation. Play therapist provides children and families with a safe, brave space to investigate and process. And I use safe, brave space because yes, it has to be safe, right? Like, or we're not going to get where we need to go with youth, but it also has to be a really a space where we provide opportunities to be brave, particularly when a youth is talking about being suicidal, which is really scary for them. They're worried about themselves, they're worried about their family, like how are people going to respond? So it has to be a safe, brave space. And my that's my bias. Right. The playroom is a wonderful space to explore and work through distress, worries, internalized depressive messages, biases, confusion, conflict. And then play therapy, we know, is evidence-based, and it's ethical, informed, and it's an affirming treatment for families and children. Now, there are some limitations to using play therapy with children who are suicidal. It doesn't work for everyone or every problem. Parents may be hesitant, right, to engage in play therapy with their child, and they may have a very difficult time with their child being suicidal. So there may be times where you're just working with the trusted adults in the situation to provide them with resources, psychoeducation, some sort of, like referrals, or even, we have to be therapeutic towards our parents and guardians as well. So maybe just offering them that safe, brave space to work through with you briefly, unless they need their own, their own really big counseling treatment, just while you're working with the youth. And then effective play therapy depends on the play therapist. So if the play therapist isn't doing, following those change agents, the therapeutic powers of play and theory, and doing the techniques that work. And we know that with youth who are suicidal, a more directive approach is necessary. And so that has to be a big part of the work that you're doing with youth who are suicidal, because non-directive play therapy is not necessarily appropriate, because you can't just empathize and you can't just really validate a youth who is engaging in harmful behaviors or experiencing harmful thoughts. You have to be more direct. We'll talk more about that. And then play therapists who are not culturally responsive can create harm. They have to be, we all have to be more aware, knowledgeable, and skilled in providing affirming play therapy for clients of all walks of life. Now, this is a big part of the ethical piece, is the self-care. Our work, what we do is it's hard work. We love it, but it is hard and it can take a toll on us. So it is imperative that we are engaging in self-care. And this doesn't just mean like going and getting our nails done or going to get a massage or, doing the things. It may include setting more boundaries to create space for us, right? It may be saying no to certain things, right? Like those things are self-care. I also look at like getting stuff done as being self-care, because if I'm not getting stuff done, then maybe my anxiety is really high, so if I just get it done, then that's self-care for me. And it's really important to recognize this, like when we need to engage in physical wellness, spiritual wellness, emotional wellness, cognitive wellness, interpersonal relationships, and professional wellness. In Dr. Brown's research, her and some colleagues just did a research study with play therapists on self-care, and so you do have a reference for this at the end of the PowerPoint. But in her research, the participants noted that the weight of this work and their overall well-being, and the need to engage in self-care practices were paramount, so important. And so my question to you, and you can just put it in the chat, how do you practice self-care? And how is play instrumental to your self-care and wellness? So I'll give you a couple of seconds. If anybody wants to speak up, you can, but you can just put it in the chat. My question, I'll repeat it. How do you practice self-care? And how is play instrumental to your self-care and wellness? Oh, spending time in nature, playing outside. Yes, Autumn. So good. Yes, nature is so healing, right? Run regularly and go to the gym. All right. Reading and coloring. Quality time with my toddler, playing with him in the way that he wants. One way I practice self-care with play is family game night. Yes. Exercising, working out. All of these are really great self-care practices and wonderful ways to integrate play into your self-care. Yes, games with the family, coloring. Ooh, right. Thank you. Thank you so much for sharing. I just think play has to be a big part of self-care, and but I'm a play therapist, right? Like I have some bias around the benefits of play, and the importance of engaging, even as an adult. Sometimes we forget that we're supposed to be playing, right? And our play looks different than kids, but you all have offered some really wonderful ways to engage in play and self-care. So thank you. All right, so here are the learning objectives. You'll identify common suicide warning signs and risk factors to support effective screening and assessment for suicidality among children in the playroom. Hopefully, my goal is that you'll be able to apply developmentally appropriate and culturally responsive treatment to children and families during play therapy, and that you'll be able to recognize the need for referrals or resources outside of the playroom. And I have some referrals and resources available at the end of the presentation. To begin with the warnings and suicide risk factors, suicide starts as a journey. There's an idea, there's a plan, and then there's a means. And it's easier to intervene early so that we can recognize and help others recognize these warning signs, particularly among youth and their trusted adults. So sometimes working with youth who are suicidal can feel like this traffic light tree that we have right here in this image. The way that we kind of understand suicide is as a traffic light. You know, you've got the red, yellow, green, and I'll talk a bit more about that. But for me, working with youth who are suicidal is like there might be significant changes in these warning signs day to day, week to week. So it can look more like this traffic light tree versus like just a regular 3-light traffic light that you see hanging. And one of the ways to conceptualize this is that you consider the risk factors as being the yellow light. So this tells us that we need to slow down, really start paying attention. And the warning signs we recognize as being similar to this red light, right? Like these are signals saying we need to stop immediately. And then the green light is one to consider as well. These might be considered those protective factors that can serve as a buffer against suicide risk. So we'll consider each of these separately. Suicide risk factors endure over a period of time while warning signs signal imminent suicide risk. The clearest warning signs for suicide are behaviors that indicate the person is thinking about or planning for suicide, or that they are preoccupied or obsessed with death. There are direct verbal cues that we can listen for. I've decided to kill myself, might be one. I wish I were dead. I'm going to commit suicide, or I'm going to kill myself. I'm going to end it all. If such and such, fill in the blank, doesn't happen, I'm done. I'll kill myself. There might be these indirect verbal cues of, I'm tired of life. I just can't go on. My family would be better off without me. Who cares if I'm dead anyway? I just want a way out. I won't be around much longer. And pretty soon you won't have to worry about me. Now, when we think about suicide, we also recognize that there are mental health concerns to acknowledge and be mindful of around this, what might be a preceptor for suicide. So a mental health concern that was specified within this study of Rush et al. Recognizes ADHD, depression, and co-occurring disorders as being the most common diagnosis. One thing I think is really important to understand is that ADHD has been found to be really significant with suicide risk behaviors due to higher risk of mental health concerns, impulsive behaviors, increased social stress and conflict with others, and then also higher uses of substances, which really can inhibit and create risky behaviors. And, use of substances are associated with suicide deaths. So recognizing these things when we're working with youth can really support us in creating these preventative measures. Now, within this study, I also think it's important among the children who were participating in this study, 78.4% were receiving mental health treatment at the time of their death. And 24.3% had a prior psychiatric hospitalization. So I think that this is really important information to share because, sometimes we get in this mind frame of, oh, they're getting treated, they're getting treatment. Oh, they've gotten support at the psychiatric unit. But, we got to recognize that children do attempt suicide even when they're getting treatment. I had a youth who I saw. I'll stop sharing for a second, but I had a youth who I saw for a session, checked in with them, been working with them for a few months, and they attempted after they left my session with them. There was no indication of ever. It was like something that I would check it, like, how are you doing? Like, I noticed you're feeling sad today. Can we talk about what that looks like, for you? And they were a tween. They were a tween. And, you just never know. You just never know. It came out of left field for me. And I think we have to recognize, like, okay, wow, for me, that was like a real, reality check of, okay, so I share that with you because for me, that was a first. And it's, it was kind of one of those experiences. And I've been doing this, for 13 years. And I was kind of like, whew, that was the first. And that was, a couple, like maybe 3 years ago. So I don't, I don't have a problem really checking in now about suicide. Not that I didn't before, but it's even more so now. Sorry, it just went through 4 slides. Here we are, we're back. So this is another study, and being a counselor educator and having my PhD, I am really big on research. So I do speak a lot to research because I think that there's a lot of value in it. So this particular study, participants were aged 3 through 17. They had current anxiety problems, behavioral conduct problems, and depression. The prevalence of each of these disorders was higher when the child's age was older and their parent or caregiver had other like mental health concerns as well. What we know through the research is that with higher rates of mental health issues, there is risk of suicide. Now, I want you to think about how many of you are working with youth whose parents or caregivers, guardians have mental health concerns, emotional health concerns. And how might that be impacting this youth and their mental health concerns? This is another study. This is 9 to 10-year-olds. Okay, the sample is 11,814 children. This is a huge sample size. Okay, very diverse. And they also had one caregiver provide data. So when you look at this, the passive ideation, 763 of these youth had passive ideation. Active ideation, 512. That's non-specific. Active ideation specific, 266. 127 had attempted suicide, and 1,000 had non-suicidal self-injury. Now, when we think about non-suicidal self-injury, we cannot say that this person is, in fact, suicidal. What we can say is they are intentionally self-inflicting damage to their body done. And we could also be on the lookout for potential suicidality if it continues, okay? Another study. This is a meta-analysis, and what this means is that the researchers took a lot of different studies and they reviewed them all and then put them together and created one research study with all this data in it. And ultimately, my takeaway from this is that us as play therapists, we have to be mindful of how trauma impacts children's development, emotional regulation, and impulsivity. Child abuse is absolutely a risk factor for suicidal behavior. We also have to take into consideration these cultural components, really recognizing and understanding the intersectional identity characteristics and how systemic and structural barriers create mental health concerns among our youth who are marginalized or underserved. So if we're talking about suicide warning signs and risk factors among youth, we have to understand and recognize that we're trained from a very Westernized perspective and maybe not taking into consideration, the hope is that we're taking into consideration trauma, right? But intergenerational trauma epigenetics, and racial trauma. We have to recognize these things when we're doing work, especially with diverse communities. And sometimes we have to think about not just treating the mental illness, but the soul wound, which is that intergenerational piece. And the soul wound is something that Eduardo Duran has brought up. He's a indigenous psychologist. And he says, you know, we're treating the individual in addition to providing outreach, advocacy, and healing services to the larger community that the youth belongs to. And we're working with the youth, right? Not just to heal the trauma, but to heal the wound that is within themselves. Okay. And that in and of itself will help to heal the land, to heal the community. The focus of this kind of treatment is on creating intersections with people and the land, because we know that trauma is not just inflicted within a person, it's inflicted within the land and within the community. And so for me, this really speaks to this cultural piece. And with this, we've got Black youth and suicide. So racial trauma has been researched, and we know that it is a leading cause of psychopathology. And with that, there is an increased risk for suicide and depression. I have cited a couple of different studies on this slide, Sheftal and Opara et al. Their work really speaks highly of recognizing the significance of it, of suicide risk among this community. We also know Black youth, you know, who are experiencing systemic barriers and other racial trauma. They are at increased risk for academic concerns and delinquency. They experience higher levels of discrimination and violence from their teachers and admin and staff, and they experience high numbers of microaggressions at school from different stakeholders. All of these things impacting their well-being. Now, with youth who are part of the queer community, you know, there's lots of research that's been done over many years. I really love the work of Caitlin Ryan from San Francisco State University. Their work is really focused on family acceptance as being a protective factor. But we know that these youth experience high rates of mental health concerns because of internalized homophobia, discrimination, increased rejection and victimization, increased depression, upbringing in religious contexts that does not affirm them, gender nonconformity as being deemed as different or unacceptable. And then these youth do experience higher rates of bullying. One other piece around this I think is so important to remember when we're talking about culturally responsive care is that research demonstrates that when a person holds more than one marginalized identity, okay, that person experiences higher rates of mental health concerns and are more at risk of suicide. So if you've got a Black queer youth, because they have two marginalized identity characteristics, socially constructed, right? They are at higher risk of mental illness because not only are they experiencing rejection and discrimination because they are Black, they are also experiencing rejection and discrimination because they are Black and queer. So then if you add disability to that, right? That's an added layer. So then it's an even higher increase of mental illness and suicidality. So American Indian, Native American youth and suicidality. It's so important if you're working with this community to recognize that suicide is the second leading cause of death among youth, Native youth who are ages 10 to 24. The rates of suicide among this community are 3 times higher than the overall net average. And there are mental health concerns that increase in suicide risk as consequences of defranchisement resulting from genocide, low socioeconomic status, alienation, cultural disconnection, and assimilation pressure, which also, increases rates of substance use. So recognizing all of these variables, these pieces in support of Native youth is going to be profound. Now, with Asian Americans in suicide, the research says this is the racial group that's less likely to seek out and utilize mental health services because mental health is stigmatized within their culture. It's deemed as being weak. They're deemed as being weak. And then this particular study says second generation immigrants are at risk of suicide, but they're still learning why they're at higher rates of suicide. But the assumption is that of racial ethnic trauma, right? Now, I can't cover all of these different things, like that would be a 2-hour workshop, I think, in and of itself. So I've just given you some ideas here to work with. This is the final one: disability, neurodiversity, and suicidality. Youth, with sensory impairments were more likely to report attempting suicide than youth with learning disabilities, ADHD, and health-related issues within a study. Risk factors connected to this: higher stress and poor mental health, negative family experiences. I would also say negative community and school experiences as well. If you have a disability, if you're working with youth who have disabilities, you hear their stories. They feel like they don't belong sometimes, that they, are not part of like they see themselves as different because they're, because of ableism, ultimately. And then the most common mental health diagnosis among children who died by suicide between 2013 and 2017, according to the Rush et al. Study, were youth who had a diagnosis of ADHD. So again, we've got to recognize the significance of ADHD on mental health, mental well-being, and suicidality. Well, this is just another study. I'm just going to kind of go over it really briefly. Burstein and colleagues found hospitalization visits for youth that had either suicide attempts or suicidal ideation were doubled between 2007 and 2015. So this is even pre-COVID, okay? This is like pre-COVID. COVID impacted our youth in ways that we are still learning about, right? And the average age for visits in this study were 13-year-olds. So ultimately, it is necessary to identify suicide when working with children. We've got to understand direct expressions and reports of suicidal ideation and suicidal attempts from caregivers or educators, right? We've got to be observing play themes and play behaviors. So, moving into play behaviors. Play behaviors are what the child is doing in the playroom, right? This is what we are recognizing our play themes through. These are those metaphors of the meaning that the child is trying to communicate. And if it's around suicide, it might mean hopelessness, right? Which can convey the internal message that Ray in 2011 says, "I have given up, nothing will get better for me or others." So Dee Ray, her work, I've provided it in the reference too. You can read more about this. Possible play behaviors that we might see with youth who are suicidal are death, drowning, destruction, failure, conflict, burying, sexualized. And when we see these play behaviors, play themes might warrant risk of suicide, and it's got to be assessed. So we'll talk more about screening and assessment in just a little bit. One example that my colleague, Dr. Brown, and I discussed as being something that could potentially be a play theme, a play behavior into a play theme of suicide would be if a child takes the toy gun and puts it in their mouth and pulls the trigger and says something like, "I'm dead," falls over. My question to you is, what might you do in this case? So I'm going to stop sharing. You can put it in the chat. Child says, "Boom, I'm dead."
It's a joke, but I don't know. That's why I'm here. I would
Huh?
freeze. That's so scary. And I have a kid, like, he doesn't like, it's not a gun, but he will take, like, he gets poison noodles a lot. And he's like, oh, I have to eat these. I don't want to be here anymore. And he like poisons himself and he dies. And so my
Wow.
official answer, I just track and kind of reflect feelings.
Okay. Thanks for saying that. Yeah. Thank you for putting that in the chat. Reflect, you want to die. Yeah. So this is one of those cases that we discussed that we have to be more direct and less like reflective in this time. I am very child-centered. That's how I was trained, so like learning to be direct was, I mean, it's been a process for me. And at the same time, when I start to think, especially based on behaviors that are like the trusted adults are telling me about, based on other behaviors that I'm seeing in the playroom, I would be more direct in saying guns are not for pointing at people. And then I would do acts, right? Like I would set the limit. And I would ask about the play behavior. I would say something like, tell me what the gun in your mouth was, which developmentally, right? We don't know, like kids might not know. But we have to let them know that we recognize that this is a very scary behavior, right? And if we're thinking about, like how we are feeling in that moment about that behavior, we have to tap into that. Like, like you were saying, right? Like, oh, I feel it in my body when I think about this youth doing this behavior. And we really have to be far more direct in saying guns are not for pointing people. And instead of, redirecting and saying you can point the gun at other people, it's a good time to maybe say, I wonder if you've thought about shooting yourself in the mouth before and dying, right? And dying. Because if we're not saying the dying word, then we are not doing what we need to do to be really specific about what we're seeing. Okay. So I want to see, is there any questions about that? Comments?
I have a question.
Yeah.
So, I was trained very non-directive.
Yes.
So it's I find it difficult to, I think of it as like breaking the fourth wall, so to speak, of shifting into directive during what was otherwise a non-directive session. And I worry about imposing limits during the session, when normally if a if a child aims the gun at me, I
Right.
fall over and I'm dead, right?
Right.
Because we're staying non-directive.
Yeah.
So I am curious about what that does to the play dynamic when we're setting limits on those things. I'm curious about that.
Okay. Yes. So my question here, I have a question back. Okay. If you like, we know toys are words, right? The
Right,
play behavior is something that they're trying to communicate to us. And
right.
if we were working at the adult and they said, I'm going to put a gun in my mouth and I'm going to shoot myself dead, what
Mhm.
would we do?
Right. We would further assess that for sure.
Absolutely.
Yeah.
Yes. And it's the same, even if we were person-centered with adults,
Mm-hmm.
it's the same thing with kids.
Mm-hmm.
We have to understand what's going on, right?
Mm-hmm.
And we can't just assume that it's like, oh, they're joking. Oh, they're just, like like they're just
Mm-hmm.
trying to get my attention, right? They're trying to make me, you know, words aren't, like around that aren't coming to me, but
Yeah.
we got to tap into it just like we would with our adults,
Mm-hmm.
because that is a communication there,
Mm-hmm.
whether they are serious about it, like serious about wanting to die or not. We still need to
Mm-hmm.
know, like, okay, where is this thought even coming from? And they might not be able to answer it, they might not know, right? Like, we know kids don't know always,
Mm-hmm.
but we have to let them know that we're worried, and
Mm-hmm.
that we need to try to figure out what's going on to keep them safe.
Yeah. That makes sense. And I liked what you said about, I wonder if you've thought about putting a gun in your mouth before. Because that to me it's in that non-directive phrasing, of I'm wondering
Yeah, yeah,
without, because in my mind, I'm like, if I say, hey, hold up, we're stopping this
right.
session, and now
Yep,
I've got a CSSR that I'm gonna do with you, that totally changes
absolutely.
everything about your session.
Totally does. Yes. And you're like, then they're like, why are we doing this? Right. Like,
Right.
then it feels right. And for me, I love I wonders, right? Like, that's my go-to. I
Mhm.
wonder, tell me more about, and so, like, engaging in the same therapist way that you would, like, oh, I wonder, or, huh, I wonder if you could tell me about that, instead of being like, whoa, hold up, then that's going to make them shut down, which we don't
Right.
want. Right. Yeah. Thanks for asking that question.
Yes, thank you. That was
Yeah,
helpful.
you're welcome. I look at this as being very similar to the work that I'm doing with adults,
Mhm.
around suicidality. There's no way, if someone said, I want to kill myself today, that an adult that said that, there's no way I wouldn't be like, okay, well, let's check in about this.
Mhm.
Like, this is that time where I need to understand more information about this.
Mhm.
Great, great.
So I have one more question, and
Oh,
I'm sorry to, I
oh,
feel like I'm monopolizing. Um,
no, it's heavy.
yeah. So since in play, we understand that play is the language and that the toys are the words. So, um, on your previous slide of, monitoring the different behavior and the different themes, I'm wondering, I'm trying to figure out a way to cut through ambiguity in assessing the different themes that we're seeing, because a child could be demonstrating themes about power and control in a
Absolutely.
way that is not indicative of suicide, at least in my mind. So I'm
Absolutely.
trying to figure out, okay, at
Absolutely.
what point do we figure, is it just a gut feeling? Is it the gun in the mouth being obvious? Like, where do we cut through that ambiguity?
Right. So that's a great question. And I think maybe my next slide will speak a little bit
Okay.
more to that. But for me, it's about like, what's the data that I already have on this youth, and what do I know that that's going on in their life, and sort of navigating that
Okay.
piece. But then my next slide goes, might help too.
Okay. I'm jumping ahead. I apologize.
Oh no, it's a great question. Yeah. Yeah. I see your hand.
Yes, I had a question. So how do you move forward when so like I have a client who I use that direct approach with when they're being um kind of aggressive like that, when they say or do things that seem like, well, kind of like your example. And I will be direct, and then I try to use the I wonder statements to get my client to talk about it. And it's like immediate shutdown because I didn't let them move forward with their talk and things like that. And I just don't know how to move forward with trying to understand where he's coming from with that, and things like that.
Oh gosh, that's a great example. So, I mean, if you're noticing a shutdown after that, and you're communicating your concerns with the adults, okay, like this is a theme that I'm seeing and it's concerning to me. I really need you, like I'm not getting any information after I check in about this. So like this is when you've got to get the parents and caregivers really monitoring things at home, and bringing back data to you. So if this is the case, then you could potentially let them continue, like without stopping them after the gun. Let's say I'm going to give you my example, the gun in the mouth, right? And then I'm going to die, or I'm going to kill myself kind of thing, right? You could let them maybe play that out, and then then you would come in with, tell me about, or I wonder about this, right? And that, I guess that would give you more data. But for me, the first time that happens, I need to, it's like with an adult, I got to do that assessment. I gotta do that screening right then, the first time I see that kind of behavior. Does
Okay,
that
that makes
help?
sense. Yeah, thank you.
Yeah. But if this is for me, and I'm sort of processing and thinking about it as we're talking about it, but if it's been a consistent thing going on in the playroom, let them play it out and then do your, okay, tell me about. Yeah. Because it
Perfect.
sounds like
Thank
they
you.
do. Yeah, it sounds like they're trying to communicate something to you. Yeah.
They just
Great.
don't like it when I'm very direct.
I know. We know, working with kids, some kids need direct and some kids don't want it at all, right? And there's just times where we can't just, provide a, empathy and a reflective statement on something. Like sometimes, like I can provide the reflective statement. Oh, it seems like, but then I also have to be like, okay, well, hold on, tell me more about this. Yeah. Yeah. Thanks, everyone. So coming back to what we were talking about, like, how do you know the difference? And I'm just going to speak to this really wonderful like interview podcast that Lisa Dion did with Heather Fairley Denbrough. And I encourage you all to listen to it. I put the link here because they offer information. I mean, I'm obviously speaking to it right now, but they offer some information that I'm not speaking to. So what they talk about with relation to suicide is suicide play feels like nothing is accomplished or shifted during the play. Things are dead forever. There's overwhelming doom. No sadness in play particularly. And then like play behaviors and post-traumatic play, suicide play feels like all of these things. Like there's no shift, nothing's happening, there's nothing being accomplished. There's a lot of hopelessness. Like, you know, the villain or the bad guy is just kind of like taking over. And then the person who's the victim is like, nobody cares, no one's saving me. But one of the things that we can do is that we can help the child to understand that they're not alone, right? Like, I'm here with you. And I love the work of Teresa Kesley at Santry Institute, and this quote here: play therapy helps children think outside the box and find new ways to solve problems. And so while, they're struggling with these things, like the no shifts, the doom, we can interject and be a little more directive and potentially help them solve problems through Santry or through providing, opportunities in the play that we do with them. Or offering suggestions, right? Asking questions. I wonder. That's my big one. I love I wonder. I try not to use it too much, but I do use it a lot. So like, yeah, I wonder too. Why do you keep saying that? But I do love that one. So I want to share with you this assessment that was created by myself, Dr. Brown, Dr. Stark, and Dr. Suri. We put together a conceptualization around creating an assessment tool to be used with play therapy specifically. And our paper is this. It was written in 2021. It was published in 2023. This is how long it takes to get a peer review article published, but is a call to action to play therapists, because in my work, I was really struggling with finding any information for many years on how to support youth who are suicidal in the playroom. So I was just kind of, when I was doing the work I was doing, I was kind of pulling from what I knew about kids and what I knew about play therapy, and like integrating the two, but there was no evidence-based sort of work around it. And so this paper kind of came out of that. And I'm going to share the assessment tool with you so that you have an idea. And you can also, I think I shared the actual article as part of your, as part of the handouts that I'm giving you all. But if not, I'm happy to share that with you. So the cross-cultural adaptation piece with the ask suicide screening questions for screening risks screening tool and then the brief suicide safety assessment. Those two tools were created by the National Institute for Mental Health. They were created for youth ages 8 all the way up to 80, 100, like you can use it for adults too. But I was really like, okay, that's great. And what I know about kids is that this is not really developmentally appropriate for where they are. So, I was like, okay, let's try to figure out something for those that are younger than 8. So when we think about youth that are ages 4 to 7, they're very literal, they're very suggestible, they struggle with keeping their attention on a task for very long, and then trying to respond to some lengthy survey with these very abstract concepts and these questions around like, over the past 2 weeks, kids just don't understand what that means. And so this is the cultural piece is like, we've created a more developmentally appropriate one. And while the ask, the ASQ questionnaire only takes about 20 seconds to administer. It's still like the questions are not really user friendly. So moving into this is a link that'll take you to these assessments if you're interested in going and looking at these, if you don't use these already. And then this is an example of the questions that are being asked in the Ask screening tool on the left side. And these are the cross-cultural adaptations of those ASQ questions for young children. So while I said, you know, we created this as a group, this is kind of how we conceptualized making the questions being asked in the ASQ more appropriate for you. So the question in the ASQ is, in the past few weeks, have you wished you were dead? And you say yes or no. The yes or no thing, that's great, right? But like I said, if you're talking to a 4 or 7-year-old, 2 weeks ago was like, I don't know, an eternity ago, and they don't even really understand what 2 weeks time and space, right? So because kids are this age are more present focused, we created a question of, do you wish you or the object, the puppet maybe that they're using as a medium to communicate, do you or your puppet, you know, your whatever they name them, wish you were dead? And this is present focus. This is asking them what's going on right now. And if you need to know or get an idea of the time frame of the death desire, you could go into curiosity again. I wonder if, you know, your friend Jemmy, the puppet, has thought of bonking their head and dying before today in the playroom with us. And then you can give them examples of places rather than being focused on time. This would help you to understand maybe a time frame better. So like, I wonder if you or Jemmy, the puppet, has thought about dying at home or at school. And then that might give you a better idea about time frame. The next question, in the past few weeks, have you felt that you or your family would be better off if you were dead? Yes or no? That's the ASQ question. Again, we bring it back to the present. Does Jemmy, the puppet, feel like you would be better off gone or dead? Do you feel like your family would be better off if you were gone or dead? And so, I mean, you wouldn't say the puppet, I want to be clear about that, but you might say Jemmy, right? The next question, in the past few weeks, have you been having thoughts about killing yourself? Yes or no? Going back to, does Jemmy have thoughts of killing himself? And then, have you ever tried to kill yourself? Yes or no? So using the child's language, right? Like we do in play therapy, we're using their language. This is kind of a reflection, right? Of, it could be meaning, it could be content. Saying, you know, I may be wrong. But I think, and sadness, so there's a case study, I guess I should have given you this information. There's a case study in the article that was published by the Association for Play Therapy Journal. There's a case study in there where sadness is the name of the toy that the child is using as their object for communicating. So using the child's language, saying, I may be wrong, but I think Sadness has thought of breaking his head before today in the playroom with us. And so this was the child's language that they use of breaking their head. Like falling, the child in the case study was going to fall off the bunk bed and break their head. And so being very specific, right, around breaking their head, using their language. And then if yes, how? So then whatever you would use that question. How? I wonder how Sadness has thought about falling off the bunk and breaking his head before today in the playroom, right? And then when would be a question that you ask, and then you get the child's answer. And then if they answer, so the ASQ uses the term patient. This is not my language, okay? But if the patient answers yes to any of the above, ask the following acuity question. Are you having thoughts of killing yourself right now? Yes or no? Okay. Going back to the adaptation, the question should be explored more with the child and the parents or guardians, because the questions presented before are present tense. So you're going to bring in the parent or guardian if you're just seeing the youth individually to ask this last question on the ASQ. And the direct question is, are you or Jemmy having thoughts of killing yourself? Now, don't use you or Jemmy, just use one or the other. So if they're using an object, Jemmy, the puppet, to communicate, you would just say, is Jemmy having thoughts of killing themselves right now? Okay. Now, before I jump into the BSSA, I want to make sure, how's everybody doing? You still here? Questions?
Not really a question. I just love just kind of the changes in how to talk to kids in a way that doesn't sound so professional too. Like it just connects with them in a way where they feel like they can be open and engaging with you. And kind of like how you mentioned earlier about continuing when you're asking those questions, still staying in your normal tone and having that genuine response to them helps them, I imagine, to create more safety with you too.
Yeah. And for me, it's like if they're using it, you know, in a medium, I'm using puppet, right? Because I'm using my hand, but if they're using a puppet, I think it like even makes it more fun, more playful to ask these questions than to say like, oh, I mean, we can be playful. Like, I wonder if Jemmy has thought about dying before today in the playroom. Yes, right? This can be, it doesn't have to be so like, flat affects, like, you know, because we are still doing play therapy, you know, like we're still in our role as a play therapist. The only thing I think that we get hung up on is, oh, this is happening, right? Like we get hung up on that and then we get out of our play therapy role and get into like serious mode, but we are still play therapists and we still are supposed to be engaging in playfulness too. Yeah. Thanks, Natalie, for saying that. All right. I'm going to move on. We're going to move into the BSSA, which is, so once you complete the ASQ and there is high acuity, they've answered yes, you know, like if the child has screened positive for suicide risk with the ASQ, the previous one, then we will do the brief suicide safety assessment. Okay. And this whole assessment is done actually with the child and the trusted adults. Okay. One thing I think is so important for us to do when we begin this is that we are thanking the child and the parents for being there, and the child for being so open to like, like, or the object, right? Like, oh, Jimmy, thank you so much for telling me about all these hard things, right? Because that's that safe, brave space piece. So the BSSA, the question is, praise the client. I'm here to follow up on your responses to the suicide risk screening questions. These are hard things to talk about. Thank you for telling us. I need to ask you a few more questions, right? Like that's the prompt for the BSSA. Here's what we decided. Per the case study, so going back to the case study in the article, we said, thank you for telling me all about these hard things, sadness. And remember, the sadness is the object that the youth is using to tell their story. Talking about wanting to die can be super hard. You've done such a great job so far, and I wonder if I could ask a few more questions. What do you think about that? And this is where you're giving the child some agency, right? You're giving them agency to give you, you're not just telling them like, you're going to tell me more about this, right? And if they say no, then you just ask the parents, right? Or guardians. But you assess the patient. So you review the responses that you received with the parent and guardian from the previous assessment. And then you screen for symptoms. So screening for the symptoms would be the observable play that you're seeing, the themes, the behavior, and including the intake information from parents or guardians. So whatever information that that the parents and guardians have given you, that's the big piece, right? Like you have this data, work with it. And then you're going to understand frequency of suicidal thoughts and assess if the patient has ability to be alone, and determine if and how often the patient is having suicidal thoughts. You can ask them, in the past few weeks, have you been thinking about killing yourself? If they say yes, then you'll ask how often. Okay. And when was the last time you had these thoughts? So that's the BSSA. Now, going back to that cross-cultural adaptation for youth, we are taking into consideration developmental level, right? And then we're going to follow that BSSA recommendation to bring the parents, guardians in, but we're going to ask a present focus question. Do you wish you were dead? Does Jimmy wish they were dead? Okay. And then to get an idea of the time frame of their death desire, again, you would go back to asking, with curiosity, I wonder if Jimmy has thought of falling off the bunk bed and dying after busting their head before today in the playroom with us. Giving them examples of places rather than being focused on time. I wonder if Jimmy has thought about bunking his head and dying at school, at grandma and grandpa's, at their friend's house, right? Like if maybe one of the last times the kids were at grandma and grandpa's house and they're like, yeah, that's the last time I thought about it, right? Then you have a good indication of the last time that they thought about it, right? Also take into consideration, all the data that is really speaking to, okay, is there potential for suicide here based on what the adults are saying? And then it's important to recognize if you're seeing these themes, these behaviors around dying and hopelessness, we have to work with the trusted adults on ensuring that the child not be left alone and perhaps having a more thorough assessment outside of the play therapy room. So sending them to, maybe the children's hospital to get further assessed to ensure that they don't need more support, right? And it may warrant that they need a referral for that. And that is not my first go-to. I worked on it, in a child adolescent psychiatric unit. It's not my first go-to. And I also know, like, sometimes parents, like, they have other kids and, they can't always be constantly monitoring. So we have to make sure that, everyone is safe and being safe. And then the suicide plan. So, you assess if there's a plan, regardless of how they respond. You ask about what method, access to means. And this would be a question, for the parent. What's the access to means? Does the youth have a bunk bed? Is there a potential that they would, intentionally fall off the top bunk bed and try to break their neck or bust their head open, right? So then no more bunk bed. Bunk bed's gone, right? Or, other things that I recommend to parents and guardians is taking the door off the hinges, and they're not being able to be in their room with the door off. And I say this because there's a high rate of children who die by suicide in their own home and in their own bedrooms. And so that is really important that we are monitoring kids in their bedrooms. And then you can ask, more specifics around, do you have a plan to kill yourself? Like, have you, I wonder if Jimmy is thinking about going home and jumping off the bunk bed and busting his head, right? And then, that might be a way to do that developmentally appropriately. Now, anytime we are doing, we've recognized suicidal ideation, we have to complete a safety plan in the same session. It's a must, have to do it, okay? What we would want to do is make sure that the child and the family have a copy of the plan and that you have a copy of the plan and it's in the file, right? What I love about safety planning is that it empowers our clients to take action and reach out for additional support, and it brings some sense of security to the adults in their life, right? Like, okay, I can do this. So there may be differences in how you broach the topic of suicidality based on cultural factors of the child and the family. However, the message of the intervention has to remain the same. You've got to be very, directive about it. I'm concerned about your child wanting to kill themselves, thinking of killing themselves, right? And we have to create a safety plan. Now, there are going to be parents, guardians that you're going to work with that are in denial. Okay. And you have to maintain that I understand this is really hard to hear. And as sometimes you have to be really, as a mandated reporter, right? Like, sometimes you have to be a little more specific and directive with them. But like, as someone who cares about your child, like, you trust me with your child, you're bringing them to me for a reason, right? This is a really big concern of mine, and I want you to take it seriously. And this is what we have to do. And if you're really worried about the youth and you're really worried that the parents and guardians are not going to follow through with something, like engaging in the safety plan or getting more support and having, then maybe a hotline call is warranted to ensure the safety of the youth. So, and then, if you're using a translator, it's really important to remember that translators are not trained in mental health. So you have to be really specific in telling them not to paraphrase and to state things that you're saying specifically, because you don't want anything lost in translation around suicide. And then, you know, if there is concern around the religious tradition, viewing suicide as a sin or mental health as something that can be prayed away, think about providing factual information to them about depression, anxiety, or the like any biological process as something to be discussed with their doctor, because we know that depression is treatable. It does need an intervention. And we have to be really serious, like, about our use needs, right? So, another piece of safety plan that we have to engage is in emphasizing hope. Okay, we will get through this. I am here to support you. You know, like, let's create the safety plan so that we can make sure that things are, you know, ready to go whenever you get home. Now, this is the kind of the typical safety plan template that you could use, or you could have the child draw pictures for each of these components, and then one of the trusted adults would write down what they're saying, right, or what they're drawing. Like, tell me about that picture. Tell me what that means. Show, you know, and then you kind of co-create it with the child and the parents. It's important that the parents understand they've got to remove all sources of danger. So weapons, medicine, knives, rope, belts, plastic bags, anything that could potentially cut off airflow, you know, and then constant monitoring, removing that door from the bedroom, not letting them go to their friends' houses or school without someone who can safely watch them, especially if they're actively suicidal, right? Making sure that they have available resources, psychiatrist, school counselor, and those protective factors, right? Future oriented, desire to live, responsibility, caring for pets, their faith, even religion. Those can all be really important. And then the risk factors. If a parent, guardian refuses to remove weapons of lethality, or they're unable to monitor or supervise, this is where you've got to do what you've got to do in your role. Sometimes parents, when they learn about this, their child being suicidal, they may begin to struggle emotionally and be unable to provide support of the plan. So recognizing all of these things is so, so important. I did want to share a safety plan. I don't have a copy of it, but I saw it on one of the play therapy Facebook pages that I'm on. And I just thought there are just some really creative play therapists out there. I'm just like, oh my gosh, you all are so bright. But there was one I saw that a play therapist created a K-pop safety plan, which I thought was so ingenious. And I wanted to get a copy of it, but I was unable to get a copy of it. But I just think there's so many creative ways that you can do, safety plans with youth. It doesn't have to be the boring, the one that we just saw. I do like the one that, where they draw each of the components, but that K-pop one, I still, and I saw it a couple of months ago and I still have it on the back of my brain. So get creative with your safety plans if you have that niche. Now, I want to go through these. I know we just have about 30 more minutes left. So I think, obviously skills and strategies for coping that counter thoughts and feelings of suicide include emotional regulation, adaptive thinking, engaging in the use interests, the things that have meaning to them. And these could potentially become a large part of the interventions that you're actually doing in play therapy with them. Okay, so really focusing on coping, purposeful coping, and practicing and modeling and facilitating these things and teaching not just the youth, but the trusted adults as well. Because, there's so many different things that are wrapped up in mental illness and suicidality, and coping helps to regulate emotions, helps to minimize negative thought patterns. It helps to bring baseline to physiology, right? So if there's dysregulation, it can kind of bring the youth within their window of tolerance. And help to minimize, problematic behaviors, helps them to react to situations in a way that are more helpful for them, right? And just in general, being able to manage stress or distress. So these are some that I have that I think are really important. So self-soothing, really engaging in the body's natural calming system, distraction, redirecting to more pleasurable activities to decrease the intensity of the emotion that they're feeling. An opposite action then is, they're just engaging in these activities that generate an emotion or experience that counter the distressing one. Emotional awareness, you're engaging in activities that promote emotional exploration and increase clarity. And then mindfulness. So mindfulness, focusing on being present, being grounded, what's going on right now for you. And then engaging in a crisis plan. So really supporting, what are you going to do if there is a crisis? What's your plan, right? Preparing them just in case. Like I said, you never know. And then, these skills can be learned and improved throughout childhood, throughout adulthood, right? By coaching, instructing. And for me, it's like, yes, let's teach the youth, but let's also teach the adults so that they're, reinforcing and coaching and practicing and doing all those things. And perhaps it will be like a nice little beautiful, connection where the adult starts using the coping strategies that we're teaching the kids. And some of these strategies here that I did pull from that Lisa Dion podcast, that again, I put another, I mean, I really loved it so much. I have 2 links to it in this PowerPoint. So encourage you to engage in that. And then again, collaborating with parents and guardians, such a vital part of preventing childhood suicide, for intervening in childhood suicide. And also, as play therapists, I mentioned all the things that you can do in the work that you're doing with parents and guardians, but you can also support them with enhancing their ability to empathize with their youth and understanding the emotional pain that they're experiencing, while also reducing that parental stress. Teach them about the 988 suicide and crisis lifeline, like make that a part of the safety plan. Okay. And then here I've included this video because this video is one where it educates caregivers to be more direct with their youth about suicide, which is so hard for parents. Like I really can put myself in their shoes around this. Like, how hard it is for us to ask youth about being suicidal. Picture what it would be like if you were their parent asking them about suicide, your own children, right? This is really hard stuff. Really hard stuff. Oh, wow, that was not what I meant to do. There is also this Daily et al. 2018 article that I have cited at the bottom of the slide. This article offers a family systems play therapy approach as a more directive approach that could potentially support you in working with youth and families in a more directive way in your play around suicide. All right. Oh, one other thing before, you can share the therapeutic powers of play with parents and guardians to help them really understand what play therapy is and what you're doing and how it is supporting the youth and how it can support them as well. Now, again, it is pertinent to be more direct and teach parents to be more direct when a child is suicidal. Love child-centered. I absolutely love that approach, right? Like I said, I was taught it. But it does require being more direct when a youth is suicidal, specifically around treatment, right? That's focused on them feeling less suicidal, right? And having access to supports. So I have here some research from, well, I guess it's not research. I'm sorry. It's the Brown article from 2021 is an article that Dr. Brown wrote in the APT magazine. So you can locate that. I have a reference for that. And then, CBT, prompting child to express thoughts and feelings, facilitates interventions, focus on positive reinforcement, cognitive restructuring, teaching and developing coping strategies. And then solution focus on strengths and skills to reinforce change. I've mentioned providing hope. That's a really big piece to all this. And then recognizing and treating those co-occurring mental health disorders. So potentially, OT play, if you're trained in OT play or know of OT play, that was created by Dr. Grant. That might be a really great directive approach to use, especially when you're integrating family work into it and using mirror neurons and enhancing connection and attachment. And then connecting with other providers to discuss their treatment. So I think this wraparound service is so key to working with youth who are suicidal. So really, getting a release of information, obviously, to work with the school counselor, the medical providers, case managers, occupational therapists, speech therapists, other stakeholders to ensure that everyone's on the same page and really working with the youth. Now, before I move on, I want to just check in. Oh, I see a hand. Yeah.
I was wondering if you could give an example of how you might, like the wording or phrasing that you might use to transition a young client from the assessment portion into safety planning. So if the child is, if we're talking about sadness, right, the puppet sadness, how do we then transition them into the safety plan in which they understand? Well, I mean, they understood the whole time, but we're being more directive about, we're talking about the child and keeping the child safe.
Yeah, so okay, so I would just, wrap up with the assessment, right? And then say, based on the information that was gathered today, we're going to complete a safety plan before you leave.
Mhm.
Is that what
Yeah,
you're asking, or am I way off?
no, I think I think we're on the same page. I'm just wondering, like for the really young children that we're adapting the assessment questions for, I guess, I don't know. Maybe I'm overthinking it. I'm trying to think about how to bring their awareness to the fact that they are the fact that we're aware of the safety concerns and they're aware, and we're bringing parents in and kind of bringing it more up to the conscious level
Gotcha.
rather than the
Yeah.
subconscious or unconscious that they were playing, if that makes sense.
Okay. I think so. So I would say, you know, based on what we talked about today, and how much I care about your safety to the client, you know, to your youth, how much I care about your safety, and and to the parents, I feel like, you know, you might need some more support. Let's do a safety plan before you leave today.
Mhm. Okay,
Yeah.
that makes sense.
Yeah.
And
Because I think if you come at it from this, like, I mean, and we do care, right? Like
Mhm.
we do. So we're not just saying it, but if we come at it from this, like, yeah, I don't want you to leave today just like, you know, and I think it's kind of a nice way to process
Mhm.
what's going on, you know, like kind of coming down and having a plan to move forward
Mm. Yeah.
can help minimize maybe some anxiety. Does that make
Yeah. Yes, thank you.
Yeah, you're welcome. Thanks for asking. So the next piece that I want to go into are is related to strategies on how to prevent suicide. Now, again, I think some of these are systemic in nature, right? The economic supports, um, specifically in protective environments, but we'll also think just teaching coping strategies and problem solving skills, and that's a huge part of the therapeutic powers of play, right? Can be beneficial. And then having support systems for our clients and their families is huge, 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 huge. Um, and then ultimately, you know, strengthening access to and delivering suicide care. So access to mental health clinics and more play therapists is just a really wonderful way to help prevent suicide. This particular chart can just be a really quick reference for you to recognize those strategies and do advocacy work potentially. Oh, did I skip a step? Yeah. So prevention, suicide prevention for all children, you know, when we think of wellness, okay, it's more than just this absence of disease. Um, it is, it is, wellness is like such an important part to emotional, physical, spiritual well-being. And mental health is an essential component to overall health and well-being. So we want to create connectedness and create attachment, create the space where they feel heard and seen, and they feel valued, and they feel like they're a part of something, and they know where to go to get help and support, right? And then we have to recognize those sociocultural, racial, political barriers that we talked about when we were talking about the socially constructed intersecting identities and characteristics. And we have to understand how to minimize the barriers for our clients. So with regards to suicide, we have to understand how to reduce stigma, and mistrust to improve engagement. So we have to reduce the stigma around overall well-being, or I'm sorry, mental health issues, suicide, and we have to create space where people can trust the system, the mental health system, to do the work that we were all, trained to do. So education is important, disclosing your limits of confidentiality, right? Providing bus tickets if you can, or gas cards. There's a school here in St. Louis. There's probably a few schools, but I used to see youth at a school that would give parents and guardians gas cards just to get the kids to school if they really needed it. And I just thought, wow, what a brilliant system, right? Extending office hours into the evenings and weekends. It's hard for parents and guardians to get their kids to see a therapist during the workday. I know that that doesn't work for everyone. I know that you might have your own families that you want to be at home with. But then also practicing in low socioeconomic areas can create more access to care. And then empowering children, educating them how to be their own suicide gatekeeper. I know it's so much information. It's just like, we're almost done. We are almost there. So this particular Missouri Suicide Prevention Network, there is a link to the resource up here in the right-hand corner. But I really love this. I love this resource that they have put together, because as you remember, we talked about suicide starts as a journey. There's an idea, there's a plan, there's a means, and it's easier to interrupt early on. And so I'm in St. Louis, and in Missouri during the 2020, suicide was the 11th leading cause of death for all individuals. So this suicide prevention network offers these different categories. So individual, relationship, community, and societal. The different protective factors that can be supportive of people. And then the different risk factors that the people might be experiencing within each of these categories. So this is just a resource for you to have, to refer to if you would like to. There's also the suicide prevention strategy. So working with the parents, making sure they have a game plan to keep the child safe. I've talked about some of these, but I would also maybe recommend sleeping in the same room as the child, asking family members to watch the child, if you're at work or if you need to go to the grocery store. It does take a village. Recognizing that Tylenol, ibuprofen, and cold medicines are highly toxic if they are taken in high doses. So putting them away and getting rid of any other dangerous items. I know I have here like rope, knives. This can be kitchen knives or X-Acto tool, the X-Acto sharpener. Tools of any kind, paper clips even. One of the things that I've seen people attempt suicide with are those, I haven't seen them in a while, but the bracelets that were made of the cord that you could climb with. I've seen people attempt suicide with those. And so even those kinds of things that we wouldn't even think of. And then if you find that the child needs a higher level of care, obviously provide information and recommendations. Here are some prevention youth programs, signs of suicide, QPR, youth mental health first aid, teen mental health first aid, Hope Squad, and then NAMI. And then this here, you can find more information if you click on this link about each of those programs. In Missouri, we have the Missouri Crisis Continuum, which supports least restrictive and least costly approaches. So they offer someone to talk to, someone to respond, and somewhere to go if needed. I would love to hear from you all if you have specific resources in your area that can be supportive. So be sure to put the name of the resource and the city and state that you're in, because we can all learn so much from each other, right? And then again, psych units are not always the best place, but they can offer 24-hour care and ensure that, like maybe they're getting on some med management and beginning some treatment. And then contact 911 if necessary. And then again, here's just some more places you can get crisis care here in not St. Louis, I'm sorry, in Missouri. We have Burl is all through the state. And then here's some more in different areas. So again, I think sharing resources is so important because I'm just one person. I can only share so many. Now, I want you to take a moment, take a deep breath, do whatever you need to do, hug yourself, think about all the wonderful things you do and the wonderful work that you do. But we have to talk about if a child completes suicide. Okay, it's part of having this dialogue. Because even if you've done everything right, there is potential for a child to complete suicide. The key takeaway is that you've got to take care of yourself. Okay. Affirm yourself by saying something like, I'm doing the very best I can, and everybody knows it. Okay. And then I am really big on bilateral stimulation or tapping. If I need a little additional support when I'm trying to affirm myself, I'll engage in those behaviors. But we have to recognize how we feel about this and know that there's potential for it. And here I have some more information on how to engage in that. Now, let's say it happens, right? A child dies by suicide. Postvention is critical care after the completion of suicide. Now, there may be guilt, grief, and suicide contagion that someone might be experiencing. So suicide contagion is like this idea, concept, phenomenon where if, someone they look up to or a friend or a parent dies by suicide, then that person may attempt suicide to be with them or to have some sort of higher level spiritual experience. The response after the completion of suicide has to be immediate and it has to be ongoing. This link here is to support you if you need to know more about postvention. But you've got to facilitate the healing for those grieving in addition to their distress, in addition to your own grief, your own feelings around this. You've got to mitigate the negative effects of being exposed to suicide, whatever that may look like within your community, and then prevent suicide among people at high risk of attempting after being exposed to suicide. Now, survivors of suicide attempts, I have put this link here to support you with this. And then SAMHSA has this resource for suicide survivors of attempt. And there's not a lot. I mean, I guess there are some resources, but I found these resources to be especially helpful around, like, I attempted suicide and I lived through it. And I've worked with people who have attempted suicide, who've lived through it and are just angry about having been saved. And then I've worked with people who just like it's been life-changing for them. It's created more hope for them. So just be mindful, not everybody who attempts suicide and survives is like grateful. And then same, vice versa. And then there are these groups available for people who have lost someone to suicide, which we also need to have resources available for them to support them, and potentially to support you as the play therapist, because you lost someone too to suicide. Here are some more resources for you. Child Mind, I really like that resource around particularly, I mean, I like that resource in general, but this one is for families and parents and caregivers around suicide and self-harm. And then there's Take 5, which is the World Suicide Prevention Day resources. There's resources for parents on how to have the talk. And then if you're in a school, if you're a school-based play therapist, there's ASCA's model around it, making educators partners in youth suicide prevention. It's a free online training. And then that post-vention toolkit can be supportive of anyone. Now, this book was released in, I think, 2024. It's great, Assessing and Treating Suicidal Thinking and Behaviors in Children and Adolescents, a play therapy guide for mental health professionals in clinical and school-based settings. I encourage you to get it. Baker and Cross have presented at APT on information in this book. Oh, another book is if you're working with LGBT youth, Transformative Expressions in Play Therapy. This book just came out in June of this year. There is a chapter in here, Thunderstorms to Rainbows, Affirming Play Therapy Strategies for our 2S LGBTQ, GE, IAP+, all the beautiful array of those identities. It was written by myself and 4 other colleagues who work with trans and queer youth and focus our research on suicide. And it is available to you. There are actually two books with lots of wonderful resources inside of it. And then this new research around experiences of play therapists supporting children with suicidal ideation. It was just released this year as well. It includes 6 play therapist narratives of working with youth. And then there are these themes. Now, final thoughts, feelings, reactions, and then here, there are these references and then those that are within the PowerPoint. All right. Woo! Thanks for sitting through this today. Thank you for sharing that resource in the chat. We have like 4 minutes left. Any questions, comments, reactions?
How do you support a child who asks to be placed in like a suicidal hold in a hospital? But because they're saying I'm feeling suicidal, like I'm going to try and go through with this, things like that. But parent and guardian won't put them there because they think that they're seeking attention.
Mm-hmm.
Even with like my recommendation that maybe we should, it's I don't know how to support a child when they're in that position where the parents are like, no, you're just attention seeking.
Right. Sometimes I have to get real direct with parents and guardians about like, okay, well, what would it look like if your child attempted suicide or died by suicide, and have that conversation with the adults.
Mhm.
Because I have had youth who have attempted suicide and it's changed the parents' perspective completely about the behavior. Like, oh gosh, I wish I would have just taken them seriously. Oh, I mean, and no parent wants to go through that. So I think having that conversation, but then also like, is this a hotline? Like, is this a real concern that you're having where the parents are neglecting with, like, they wouldn't not take them to get medical care, I hope, right? If they needed, if they had a bleeding wound and needed medical care, they wouldn't not take them. I don't know. Those are sort of the things that come up for me.
Can I
Yeah,
also
that's
add
helpful.
something?
Thank you.
If I could add something, I have had this conversation with my clinical supervisor as well, and something that she told me that was really impactful and I felt like is a really good kind of perspective shift for parents is that if they think that their child is just doing this for attention or they're not really going to do it, blah blah blah, reminding them that children die by suicide accidentally all the time.
Mhm.
So even if they're doing it for attention, and maybe they don't plan to complete suicide, it does happen. So that for me was a really like, oh yeah, that was really a perspective shift. So that could also be something that might help parents really see the gravity of the situation.
Yeah, thank you. That lots to think about.
That
That's
was good.
helpful.
Yeah, that was so good. Well, I want to just thank you. I'm mindful of time, but thank you all so much for coming and attending today. I really am passionate about this, and I'm grateful to have shared it with you. Hopefully, it is helpful in your practice.
Yes, thank you so much, Katie. Like everybody else said, like this was a phenomenal training with so many great resources, and really makes you be mindful on how you address suicidality within youth compared to like how we do it with adults. Thank you again, Katie, for all of the information, and just for an overall great training.
Thanks
Thank you
for
all for
having
coming and
me.
listening. And don't forget that you need a training.
Yes, thanks for having me. Thanks for coming.
Thank you for joining in on today's training. We look forward to having you join us again. Heart and Solutions is proud to provide CE-eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below.